Go live. Good afternoon, everyone. Today is Friday, March 5th. I'm Melanie Griffith, Chair of the Senate Budget and Tax Subcommittee on Health and Human Services, here with my colleagues and our colleagues from the House Appropriations Subcommittee on Health and Social Services. We have two budgets that we will review today. We are members going to switch up the agenda, and we will hear the MDH Developmental Disabilities budget first, and our analyst will be Ann Wagner. Good afternoon, Ms. Wagner. You can proceed.
I'm sorry, was I muted that whole time? I apologize.
Yeah, I thought it was me. I was like, uh-oh, was I muted?
I was so good this whole session. This is the first time. I apologize for that. So presenting DDA, I'll jump right in. I know we're busy today. So the fiscal 22 allowance budget's $1.5 billion for DDA. And I'll just say from the start, about 94% of this budget pays for provider reimbursement for services for developmentally disabled individuals. And a majority of these expenditures receive a 50% federal match through Medicaid waiver programs. So that's why this budget is about, or is almost 50-50 general and federal funds. So moving on to the performance analysis section. DDA has been reporting data on COVID-19 among DD individuals and direct care staff. So it's shown in this chart. The first bar shows the rate of COVID deaths reported statewide on MDH's public dashboard. And that shows that about 2% of cumulative positive cases were reported as confirmed deaths. DD individuals have shown substantially worse health outcomes from COVID, with a rate of death at a little over 5% of positive cases. While the CDC has published that having a developmental disability does not inherently increase the risk of having severe illness from COVID, any DD individual with serious underlying medical conditions is at higher risk, as would the general population with underlying medical conditions. We are seeing a higher rate of death as from what's reported. Among direct support professionals, the rate of death from COVID was actually at the same level as the general population when looking only at adults of working age. That was about 0.7%. So DD individuals and their staff have received phase 1 priority in the vaccine distribution. DDA recently discussed a few efforts that it's taking to support access to vaccines while the supply is so limited. So this included a new effort where local health departments will hold vaccine clinics at a selected DDA funded provider each week. That's in coordination with the Maryland Department of Disabilities. And then another action DDA is taking is to conduct surveys of providers to get a better idea of how many DD individuals and staff members have been vaccinated to date. And then third, there's a pilot that has started with the ARC of Prince George's County. And that pilot would specifically host vaccine clinics that prioritize vaccinating the DDA community. So then moving on to the next performance measure, this has to do with the Dda State Facilities. There are 3 state-run facilities that serve a small share of DD individuals who are funded by DDA. And I will just note that the SET unit, one of the 3 facilities, had recently relocated at the start of 2020. So this is the unit that serves 100% court-ordered individuals within DDA. And that is now housed in 2 residential cottages at the Potomac Center campus in Hagerstown. So DDA annually reports on aggregate safety measures for these facilities. Most recently, the number of resident-on-resident assaults increased again for the 3rd year. This was partially attributed to the pandemic, as residents couldn't attend their typical off-site programming and more programs were held at the facilities. And then the SET unit relocation was also mentioned as a contributing factor, as there were more Potomac Center residents sharing rooms because they were limited to the remaining cottages once the SET unit took 2 of the cottages at the Potomac Center. And then when it comes to the staff safety, we just note that this year, the state psychiatric hospitals have began reporting a new measure for the rate of staff assaults, and that's the rate of staff assaults per 1,000 patient days. And they report this at each individual psychiatric hospital. DDA did not use this measure this year, and it reports its aggregate safety measures of all facilities in one measure. So there is a DLS recommendation that DDA begin reporting the new staff safety measure next year, and that each facility's assault data is reported separately. So then moving on to the third performance measure, this looks at DDA's new processing goals for person-centered planning. This is the process that DDA uses to determine which types of services are appropriate and needed for each individual. These plans must be approved annually, and DDA has set a goal for case managers. They're referred to as CCS. The processing goal is shown in this inner ring. The goal is that all plans are submitted within 20 days of an individual's annual due date. So you'll see from this exhibit, DDA only expects about 17% of plans to be submitted by the CCS, by the case managers, within those 20 days of the annual due date in fiscal 21. DDA reported that case manager positions do see high vacancies and turnover, but because case management is handled through contracts, the vacancies in these positions are not tracked in DDA's regular personnel. And I'll also note here that DDA is undergoing an overhaul of its community services program that will come up multiple times throughout this presentation. But that includes establishing new service definitions. So that piece of the transition plan would require all individuals to receive updated person-centered plans before switching to the new LTSS IT system that we'll talk about later on. But that makes timely process of these person-centered plans a critical part of the agency's transformation plans. And then the only other item on that is that the process for person-centered planning has changed in the last year. So DDA should explain why there are delays in processing and how it is assisting case managers in submitting these plans on time. So then the last performance measure looks at the waiting list, and this shows eligible individuals who are not currently receiving DDA funded services. At the end of October, there were a little bit over 4,000 people on the waiting list after DDA reported increased service placements in fiscal 20. That brought the waiting list substantially down at the end of fiscal 20. And then not shown in this chart, but DDA also keeps track of transitioning youth that receive a special priority from the waiting list. And I'll just note that during the pandemic, transitioning youth who would normally have aged out of autism waiver services under MSDE can now continue receiving those services until the end of the national state of emergency, rather than transitioning to adult services under DDA at the time of aging out after aging to 21 years old. So that's just a note of one of the pandemic impacts is that autism waiver services have been continued. And then moving on to the budget discussion. So you've now heard about the 6.2% enhanced Medicaid match in the BHA and Medicaid analyses. DDA also receives this enhanced match for the duration of the national COVID-19 state of emergency. So this exhibit shows the DLS estimates in red for what DDA could expect to receive from the enhanced match. Through the fiscal 20 closeout process, DDA did not differentiate any federal funds for this enhanced match, and it also did not revert any general fund savings like what was seen in the Medicaid budget. So DDA also at that time would have had increased pandemic related costs. That was mainly for retainer payments that it was approved to pay providers through an appendix to its waiver programs. But even considering the total pandemic related spending through that appendix, DLS still estimates that DDA would have seen about $16.8 million in additional federal funds, resulting in equivalent general fund savings that would have been reverted, but we didn't see reverted in the fiscal 20 closeout process. So there is a BRFA recommendation to reduce the funding in fiscal 21 through a planned reversion to account for that enhanced match that should have been earned on fiscal 20 spending. In fiscal 21, the enhanced match and the pandemic related costs are both accounted for in the budget. So that's why you're seeing the blue bar here. And that was added through deficiencies. And then in fiscal 22, after the budget was introduced, there was an announcement that the national state of emergency would be extended to the end of calendar 21. And so this, the timing did not allow for the budget to or the governor didn't know that when the budget was introduced. So the enhanced match is continuing for 6 months of fiscal 22. And after estimating the enhanced match and then accounting for funds needed for those pandemic related expenses, that would also be continuing because of the continuation of the national state of emergency. DLS is recommending a $37.8 million general fund reduction. And that's in anticipation of the 6.2 federal fund match continuing into fiscal 22. So then moving on to the other discussion in fiscal 20, this has to do with DDA's recent underspending of its general fund appropriation. This exhibit shows net fund transfers and general fund reversions. And so this shows that DDA has underspent between 1.9% and 5.7% of its annual general fund appropriation for community services since fiscal 2017. From fiscal 18 to 20, DDA has also been showing increased budgetary transfers out of its community services budget, and that funding has been used to cover shortfalls in other areas of the department. DDA has previously attributed its general fund surpluses to greater federal fund attainment or from savings based on the timing of when DD individuals started their services. But it is concerning that these general fund surpluses are being transferred out at an increasing rate. So as a result, there is a DLS recommendation for budget language that restricts the funding in the community services budget to that purpose and prohibits the funds from being transferred out. So then turning to the fiscal 21 actions, there are 4 deficiencies. I'll go over them very briefly. The first adds funding to accelerate the 4% provider rate increase from the scheduled July 1st up to January 1st of 2021. There's also a deficiency adding the Appendix K pandemic related costs that I just discussed. So that'd be 20 million added to fiscal 21. The third deficiency reduces funds due to 2 contracts not being filled. I will note that both of these contracts have been the subject of prior OLA audit findings. And then the last deficiency recognizes $72 million in enhanced federal matching funds. And so you're adding $72 million in federal funds that are offset by equivalent general fund savings that are being reduced from the budget. So then I will jump ahead to talking about the fiscal 22 allowance. DDA's budget grows by about $75 million. This is driven by changes in the community services budget. This increase is mainly driven by about $55 million added for expansion. That funding will be used to place people off of the waiting list and to extend more services as needed to people who are already being funded by DDA. I'll note that this expansion funding amounts to about 4% of DDA's community services, or a 4% increase to DDA's community services budget. And that's in addition to the mandated 4% provider rate increase. And so then the next item that drives the $75 million growth in this budget is the cost to annualize the 4% increase from January 1st to all of fiscal 22. And then the other budget fiscal 22 item I wanted to highlight is that there was legislation passed last year that requires employees of state facilities with an admission rate over 75% forensic or court-involved individuals to receive the same salary as corresponding employees at Perkins Hospital. In DDA, this applies to the Potomac Center, so there are additional funds budgeted in DBM for these salary enhancements. And then to go over regular personnel, DDA sees an increase in fiscal 22 of almost 14 positions. Those are mainly being transferred from other state facilities, and that's related to the set unit relocation. So then this exhibit 12 on page 23 shows vacancy rates by program. And we would just point out that it's concerning that all programs show vacancies above 10% within DDA. I'll especially draw your attention to the vacancy rates being closer to 25% for program direction and for the SET unit. As DDA is going through its system-wide transformation and is operating the 3 state facilities during the pandemic with greater safety measures and greater public health measures, these vacancy rates are very high and would create operational challenges. So we just wanted to highlight that here. Moving on to the issues discussion. The first goes over federal and state programs that were made available to DDA providers as they were dealing with the financial losses and the change in service delivery during the pandemic. So this first exhibit discusses Appendix K, and this was also covered in the MDH overview analysis, but this issue looks specifically at the DDA providers and how the pandemic has led to widespread program closures since a lot of day and employment programs are meant to be out in the community. So there was a lot of closures within those specific service types. DDA could not provide monthly utilization data to assess how much the pandemic has impacted the services being provided. But DDA did report anecdotally that utilization has been down. So then going back to Appendix K, this was the this was one federal approval that DDA received to allow for program flexibilities, such as allowing for telehealth services or remote services. And this is also where you're seeing the retainer payments that were approved by CMS. In fiscal 20, these costs were estimated to be about $22 million. And then in the first quarter of fiscal 21, this was estimated to cost about $5 million total. And again, there's a deficiency adding $20 million total in fiscal 21 to cover the pandemic costs from Appendix K. And then the other item since the MDH overview presentation, DDA has received approval from CMS to extend some of these flexibilities, specifically allowing for remote services past the point of the national state of emergency. Another federal source of financial aid for providers has been the Provider Relief Fund. That was discussed at more length in the overview. And then talking about state programs and assistance, the governor announced in December that the 4% rate increase scheduled for July 1st would be moved up to January 1st of this year. And so this is estimated to provide an additional $28 million to providers over those 6 months. However, because of, and I'll slow down here, it gets a little confusing, but because of DDA's prospective payment structure that's in effect for most providers, the schedule for payments is set so that the January and April payments to providers is actually based on the services provided in the first 2 quarters of the fiscal year. So this is done as part of a reconciliation process for prospective payments. And so that basically means that providers will still be owed and can claim the 4% rate on services provided starting in January, but the payments from DDA actually won't reflect that 4% increase until July 1st. So DDA does not have any plans to accelerate the actual payment of that 4% increase to any date earlier than July 1st. So most of the deficiency for these rates would not be used in fiscal 21, and it would need to be accrued for fiscal 22 payments. So then I'll move on. A few of the other state programs supporting DDA include $5 million from the Relief Act that will be available as grants. DDA also handled some PPE distributions for providers. And then there were the $10 million earmarked from the nonprofit grants administered by DHCD. And I'll just repeat here that from this grant program, DDA providers received about $5 million, but $2 million from the $10 million earmarked was actually undersubscribed. So then I'll move on to the final issue in this analysis, and that's an update on DDA's system-wide change to its community services program. DDA is moving from a prospective payment system to a fee-for-service rate structure, and it is implementing new rates and service definitions and transitioning to an existing IT system called LTSS that is currently used by Medicaid programs. So page 29 shows the timeline of major events related to the systems change. There are two items that I'd like to highlight for you today. So first, on June 15th of 2020, DDA announced that it was postponing the planned system-wide switch to LTSS, and that was originally, or that was going to take effect July 1st of 2020. But this announcement was made partially due to the pandemic. And at that time, a new date for all individuals and providers to switch to LTSS was not announced. The other thing I'll note here is that despite delaying the overall switch of the entire community services system, DDA did move forward with its phased transition specifically for personal support services. So this was implemented because a federal law passed, it's marked here, passed in I think 2016, required that all Medicaid programs comply with electronic visit verification. So that's when staff members go into someone's home and provides personal care services. There was a federal requirement for a specific type of verification of these services. The due date for EVV was June 1st of 2021. And if states didn't comply, then there would be financial penalties to the Medicaid match for personal care services across all Medicaid programs. So for DDA, this affected their personal support services, and DDA, to comply with this federal requirement, set it up so that the EVV technology needed was only set up to work with LTSS. It was not backwards compatible with the legacy PCIS2 IT system. And so this is what contributed to personal supports being transitioned to LTSS through October to December of 2020. And so this transition applied to 149 providers total, and then over 4,200 individuals receiving personal support. So DDA phased this in by region. And you can see from this chart kind of how the implementation moved forward, with December 1st being the day that more than half of the providers and individuals affected were moved over to LTSS. And just from an operational standpoint, to make the switch from prospective to reimbursement payments, DDA had to provide advance payments to cover that period when providers would not have been reimbursed yet for services provided. So DDA has not collected back any of those advance or bridge payments that it made, but it has reported that it plans to recoup some of those funds prior to the close of fiscal 21. And then I'll also note that the individuals and providers shown here does not cover the individuals that self-direct their services and receive personal supports. This is because self-directed services are actually billed through a financial management services contract. And so that is separate from the LTSS system. And because this group didn't meet the EVV requirement by the deadline, there is expected to be a penalty on that group only. So DDA will be providing, or should be providing, an estimate for the financial penalty in their remarks. And then moving on kind of to the transition, the LTSS transition, and how it applies system-wide to the other individuals and providers that have not been moved over yet. Like I said, there has been a delay announced, but it's still not clear when the entire system will be moved to LTSS, and there was no new date published or announced. Last year, there was a bill that delayed the LTSS transition until DDA met a list of different tasks and reporting requirements. The governor vetoed that bill last year, but that veto was overridden in this legislative session. And so that has to do with Chapter 7. And I've listed a few of the provisions in Chapter 7 here that these provisions prevent DDA from requiring providers to switch to LTSS until it meets the requirements outlined in that legislation. One provision I will highlight is that DDA must include each licensed provider in a pilot. And the providers are able to select the number of individuals they serve. That will be included in that pilot moving forward. And so, like I said, this is not an exhaustive list of the Chapter 7 requirements or provisions on DDA. And so DDA in addition to what's listed here, DDA will have other provisions and requirements related to the LTSS transition that it will need to comply with. And so for the time being, DDA is expanding its existing LTSS pilot group to 9 more providers who have all volunteered to make the transition to the new rates and the LTSS system. So they will be making that transition. The 9 providers who volunteered will be transitioning on July 1st of 2021, and that's after completing an impact analysis on their budget. And so DDA is requested to provide a DDA is requested to provide a timeline for how it will be meeting the provisions in Chapter 7 and how it will be undergoing the system-wide transition from now forward. So then to cover kind of the impacts on the state budget, the fiscal 22 allowance is still based on the former rates under the prospective system, even as all personal supports are now billed through LTSS and more individuals are switching systems, with the over 2,000 individuals moving over on July 1st. There are also going to be costs to the LTSS transition, especially for those advanced payments that would be needed for transitioning providers from a prospective payment to a reimbursement payment. However, there is no funding in fiscal 22 that is specifically allocated to the new rates or transition costs. And most recently, the cost estimates for the LTSS transition plan showed that if new rates were in effect in fiscal 20, community services would have increased, or the expenditures would have increased by about $97 million. So it is concerning that the budget does not show any funding specifically to support the new rate structure or bridge payments that would be needed. And then finally, switching to fee-for-service reimbursement should allow DDA to greatly improve its data collection for service utilization and will ideally improve its budget forecasting moving forward. So there is a DLS recommendation that would restrict funding until DDA submits a plan for how it will provide monthly service utilization information to DLS and how it will change its spending forecast to be based on the new rates. So then I'll briefly sum up the other recommended actions. This first action requests the new staff safety measure and safety measures reported by facility. The third action would restrict the community services budget to that purpose. And then the fourth action reduces general funds in anticipation of the enhanced Medicaid match continuing into fiscal 22. And the one BRFA recommendation reverts $16.8 million to account for the estimated Medicaid match that would have been earned on fiscal 20 spending. So I think that covers it, and I'll conclude my presentation here. I'm happy to answer any questions.
Thank you very much for that presentation and information. I am looking to see if we have any questions, Madam Vice Chair. I don't know if you see any from the House members. I don't see any questions for Ms. Wagner. Okay, thank you very much. Members, we're going to hear from the department. I have Mr. Webster Yee, Assistant Secretary of Health Policy. Mr. Yee, good afternoon.
Good afternoon, Madam Chair. Can you hear me all right?
We can. Would you like to introduce your colleagues, or I can do that, whichever?
I shall, very briefly, Madam Chair. Madam Chair, Madam Vice Chair, Webster Yee, Assistant Secretary of the Maryland Department of Health. With me are my colleagues, Deputy Secretary of DDA, Bernie Simons, Valerie Roddy, Director of DDA Fiscal Services and Operations, Jordan Butler, our Chief Financial Officer, and also available for questions, Mr. Fred Doggett, our Inspector General. I apologize that Secretary Schrader is not able to join us today. He is with the governor opening up the Charles County mass vaccination site this afternoon in Waldorf. Very briefly, we've submitted detailed responses in writing to the committees. We thank Ms. Wagner and all of her DLS colleagues, as well as the budget subcommittees, for working with us over the past 45 days worth of budget hearings. This is, I think, one of the last budget hearings that the committees will have, if not the last. And we really thank both committees for their support assistance, and thoughtful questions. With respect to the Developmental Disabilities Administration, the department has certainly prioritized individuals with intellectual and developmental disabilities with the vaccine distribution effort. In fact, we've really prioritized the ARC of Prince George's County and Melwood, in Prince George's County as well, and Charles counties, and we've focused on including IDD in the state's equity vaccine operational plans that the governor announced yesterday. As the members may know, IDD individuals have been were eligible for the vaccine early on in phase 1B, which was released back in mid-January. We've also requested that the federal retail pharmacies, CVS, Walgreens, et cetera, include individuals with intellectual and developmental disabilities as part of their the folks that they vaccinate, along with Marylanders over 65 and educators. Over the past year of the COVID-19 pandemic, my colleagues in DDA have worked tirelessly with providers and individuals to ensure that PPE has been put out and with technical assistance in protecting people to the extent possible against the coronavirus. Lastly, my colleagues have worked extremely hard to minimize COVID infections at our DDA facilities, and as discussed at previous budget hearings, we have done everything we could as a department to ensure that vaccine is made available to those who want it. And with that, I will turn it over to my colleague, Mr. Simons, for brief remarks, and we'll be happy to take questions.
Good afternoon, Chair
Griffith.
Griffith and Vice Chair Valentino, and all the members of the committee. I'm Bernie Simons with DDA. My remarks are just going to be very brief. As Webster just said, that we had the opportunity to distribute PPE. We did work with the state Medicaid office to do an Appendix K, which gave some relief and the ability to do services differently. But what I want to stress here is I want to applaud all of the people in services, because this was changing on a dime. One day people were going out into the community and being able to get their services, and the next day everything was basically shut down. And so, people were really resilient. They were very creative. I have to congratulate all of our provider community, in addition to the families and individuals, because they did a great job in working with individuals to do remote support so that people didn't lose their skills and could keep moving forward. And as we started to get vaccines, they've done a great job at working with the federal Walgreens and CVS. We've got many, many people who have been vaccinated, who receive services from DDA. We've had great partnerships with the local health departments that have been working with us. And I think that this, knowing that it was such a trying and difficult year, people just moved right through it and took the challenges and kept moving on. So with that, I'll stop.
Thank you very much. I'll start us off with questions. I guess this would be for you, Mr. Simons. I know that Ms. Wagner talked a bit about the LTSS system and all that's at stake for us as a state in terms of its implementation. I wondered if you might just talk a little bit, and we talked about the bill that was vetoed last session and ultimately overridden just a few weeks ago. Can you tell me a little bit about where we are in terms of that exchange of electronic data piece of LTSS, or have you started making plans for that? If you could just touch on that a little bit.
Sure. And so where we are is with SB 796 that was overridden. We are back looking at that. There were some elements in there that talked about, as the analyst talked about, the EDD, with the Cures Act from the feds. So, we're trying to parse out what we need to address and what we need to move forward with. We need to develop a plan. We know we have additional providers. I think, as the analyst said, There are 9. I don't believe all 9 will be going live on July 1 because it takes a different business model and a different infrastructure. When you give prospective payment on the front end, you give people a lump of money that then they can use, and then, you know, as they move forward and provide services, they then give us the verification that the services were provided. Now we're going into about 42 different services that we have within DDA that are discrete services in LTSS. That's going to be a little bit of a game changer in how the business operations are going to look. And I've had multiple conversations with the first 5 providers that raised their hand and said, you know, I will want to be an early adopter. I want to put my agency in 100%, but I need to look at some of my current informational technology systems, because we're going to have to collect data so much differently than what we were doing before. I think that the challenge is going to be in looking at developing a pilot, as SB 796 talks about, is looking at, well, what does that look like per provider, and what is the readiness of their IT systems in order to be able to gather the information to upload into LTSS. So I think it's going to take a good collaborative effort with, like, as an example, all of our regional offices, along with our residential providers and day providers, about what does this look like. So this is going to take a lot of planning if we're going to be very successful.
Thank you for that, and certainly keep us posted on that. We are, watching the process and very interested in seeing how things move forward. I see that the Vice Chair, Valentino Smith, has a delegate has a question.
Thank you, Madam Chair. I didn't see any of the other delegates, but I'm struggling to see full screen, I think, just because, just quickly, thank you, Deputy Secretary or Assistant Secretary and Mr. Simmons. I know it's been a rough year, not only for your staff, but the people that you serve. I just wanted to ask or get some quick clarification on page 8 of the report. It talks a little bit about the delays in the case managers processing their person-centered plans. And I had a chance just briefly to read your response to that. The concern is that, in talking to the community, they're concerned that the portrayal somehow is that the CCS are getting their information in late. And the concern is really that they believe that they're getting things on time, but that there's a delay with the DDA response, or that DDA is then asking for more information and resetting the time of the submission. So does your system, internal system, allow the opportunity to see the date of original submission?
Madam Vice Chair, I'm going to ask my colleague Valerie Roddy to take this one.
Thank you.
Good afternoon, chairs and vice chairs and members of the committee. Delegate Valentino Smith, we've been working with the CCS agencies. They were the first among our providers to transition into LTSS in August of 2018. When we moved into LTSS, one of the things we did was we totally revamped what we used to call individual plans, which was, really a map for, what services the person, wanted, and which providers would provide those services. We knew that individual plan was not as robust as it needed to be. And so DDA did some research, looked at some other national tools, and really adopted a new person-centered plan. And during that process, we did work with our case management agencies to get their input on how to move forward, what we should move forward with. And one of the important features was to really capture the desired outcomes of the individual, not just what they need, but really where did they want to go? Did they want to get a job? What was going to be the path to help them find a job? So we really wanted to make it more robust, and certainly, as the title portrays, more person-centered. It was a big lift because it was, as I said, a more robust tool, required more time. really on the part of the whole team, but particularly on the part of the CCSs. Moving into LTSS, it was a new IT system. It was designed to incorporate all of those functionalities for the development of the PCP, to be able to transmit that to the regional offices so they can review and approve it. But an important component also of the person-centered plan is what we call the detailed service authorization. So once all the planning part is done, then we synthesize it down and say, okay, so what services are needed to help this individual meet their desired outcomes? And so that was, we had to put that tool, it was operational, but we put it to the side for until July of this year, because it relates really totally to all the new services and the new rates in LTSS. So providers have been still working in our legacy system, and they're still using our legacy services. This was a big transition for the entire
Ms. Roddy, I didn't mean to interrupt you. I'm sorry. I think the question may have gotten, I appreciate you explaining the whole system, and it's complicated. I guess the concern is that the budget analysis is creating the impression that the CPS reports are really, really delayed. So the question is, in the LTSS system, can you see the date of the original submission so that we can better see, are they truly delayed? Or like you said, in this complicated process, is there an extended DDA time that's really causing the delay? Which it sounds like it's understandable, but where the delay is occurring, because the federal money obviously is relying on approval of these.
You're right, the federal money is relying on the approval. So the delays, so there are a couple of reasons about the delays.
Can the system, I'm sorry.
The system can show.
You can show the date of original submission.
And we are tracking that currently. That's one of the things that we've done, is that we have an internal tracking reports that we look at on a regular basis. And we're pulling from the system, when was the plan submitted to the regional office, and how long is it with the regional office? One of the things to keep in mind is that, sometimes when it comes to the regional office, staff may have questions. There may be follow-up.
Oh, yeah. No.
Absolutely. But also from the CCSs, they are developing the plans with the person's team. And they also, within the system, do get notices 30, 60, and 90 days in advance of the due date of the PCP. Because we really do want to get it in. I mean, the goal is to have it 20 business days before the PCP is actually due. But even earlier is better. And we do get plans that meet that timeline. I don't want to insinuate that it doesn't. But
no, thank you. It sounds, Ms. Roddy, it sounds like after session, I would like to come down and follow through with it more. It was more just getting to the point that there is, I think, some discrepancy with the industry, that they are actually submitting on time. And we just want to get back with you to see the LCSS information, that you can see the dates of original submission. So I really
absolutely
appreciate that. Thank you. And thank you, Madam Chair.
Thank you. We have Delegate Henson.
Thank you, Madam Chair. I wanted to ask the department if they could comment on the vacancy rates. I believe that chart is Exhibit 12 on page 23. And I apologize if the department has done so already. And thank you for the presentation to our analysts, and also for the comments already made by Assistant Secretary Yee. But if the department had any comment on the vacancy and how we could help. It sounds like the enhancements to salary might not be doing the trick, or maybe it just hasn't had sufficient time. But did the department have a comment on that?
Thank you, Delegate Henson. I'm going to ask my colleague Bernie Simons to take this one.
We've been working on these the vacancies for a period of time now, and we've made some headway. And then we had some people who retired. We lost people in our headquarters when you program direction numbers. That includes us. And we had people who decided that they wanted to get married and move out of state, and it happened right before COVID. And so, we've had a little bit of a difficult time this year recruiting. I think we've been a little bit better in the past. than where we currently are. We do rely on our Office of Human Resources, and they do have a professional recruiter on staff down there that we interact with and work with all of the time. So I think that I'm not sure where people are with looking for other jobs. We just had an opportunity to hire somebody 2 weeks ago to replace Miss Roddy, who's retiring in a month. And so, we were very fortunate and, used a recruiter and, that's for DDA, that's a vital position for me. I mean, that's my director of fiscal and operations services. And so obviously a lot of the comments about LTSS, our budget moving from prospective payment to fee for service would probably stop us dead tracks here if I didn't have that position, filled and whatever. And it gave us an opportunity for over the next few weeks, obviously, to do a transition. But we are concerned with that also, and we continue to work with Human Resources.
Mr. Simons, is there anything on the second half of my question about any additional support or anything else that we could do on our end to be supportive on the hiring? Are we overlooking anything?
No, I don't think so. I think that we've been fortunate enough to take a look at the positions that we have evaluated. And then we also have had the opportunity to hire some contractual positions also. One of the things that was more of a lift for DDA was that we now review 100% of all of the annual plans for every single person, and to put that into the LTSS system. We did not do that in the past. With the prospective payment system, we only reviewed the plans where there was a change in the services. So if somebody was going from 1 year to the next year and everything stayed exactly the same, DDA was not looking at those annual plans. Now, where the LTSS system is going to be the platform for payment, everybody's going to be reviewed. So we were fortunate enough to be able to get the authority to hire some contractual positions. So, I think that this is a little bit of a work in progress for us as we move forward. I don't think we anticipated as much of the volume and the length of time that it takes to review an annual plan. And so I think that as we continue to move along, I think we've had a lot of support from our current secretary and our previous secretaries.
Thank you, Mr. Simons. Thank you, Madam Chair.
Thank you, Delegate. I don't see any additional questions from the subcommittee members, so we want to thank you again, Ms. Wagner. Madam Vice Chair, was that another question? Okay. Now we want to thank Ms. Wagner again for this very detailed analysis, and thank you, Mr. Yee and your team for your presentation. We do have several members of the public who have signed up to testify on behalf of this budget and a few in opposition. So I'm going to start with those who've signed up favorable, and we will hear from 4 presenters, and then I'll pause members to see if you all have questions, and then we'll move on to the next group. So let me also say to the public that some of the members who you may not see on screen are testifying on bills in other committees, and so we don't want you to read anything into their absence, except for that we are all doing the state's business. We're just in multiple places at the same time. We're going to call on Tracy Polyeth, Karen Adams-Gilchrist, Andy Culp, and Marguerite Warner in that order. So we will start with Tracy. If you're in the room, you can start. Good afternoon.
Good afternoon, Madam Chair, Madam Vice Chair. Thank you for the opportunity to testify today. My name is Tracy Polyeth, and I am the Director of Government Relations and Advocacy for the Chimes. Chimes has provided services and supports to people with disabilities for 70 years. Currently, we work with approximately 1,000 people in Baltimore City, Baltimore County, and Montgomery County. I am here today to share with you what a tough year it has been for providers of supports to people with disabilities. As a large nonprofit organization, Chimes has not been eligible for much of the federal money that was offered to nonprofits. So this year has been very financially difficult for us. We had to shut down our day programs and turn on a dime and make our residential programs into 24/7 operations. Many of our day program staff did not accept positions to work in the residential program, and so it was not as simple as moving people over from one job to another department. Applications for frontline staff positions have dropped precipitously, and the predicted large pool of applicants that we would have when other non-essential businesses shut down never materialized. Between the cost of personal protective equipment and overtime and needing to keep our residents in the home as much as possible, it has been an interesting year indeed. I'd also like to share another problem that we have faced, which has been a lack of clear guidance from DDA on the retainer days. As you know, those are the days when a person is not in the provider home and has gone to the hospital or to visit a family member, and normally we wouldn't be paid for those days, but we do get payment for a certain number of them. In just this year, we have gone from having 30 retainer days per person to 18 retainer days per person to 60 retainer days per person for the duration of Appendix K. Once Appendix K ends, we will return to 18 days. And that limits the availability to persons that we serve to leave their home due to illness, due to wanting to see their family, due to going on vacation. I'd also like to share that as providers, we are required to have third-party financial statements and attestations completed. The changes and delays in guidance have caused significant administrative burden and expense as error reports are submitted to the department, withdrawn, and then resubmitted. In most cases, providers will have to redo their audits or stop those already in progress because of this lack of technical assistance. While DDA seeks guidance from CMS on these matters, providers are left without knowing what their financial outcomes will be for fiscal year 20 or fiscal year 2021. This has wreaked havoc on our budgets and our cash flow and taken away from the true focus of our providers, supporting people with disabilities. I want to thank you again for listening to my testimony and for your ongoing support, and ask that you keep the governor's 4% increase in provider rates in the budget. Thank you.
Thank you. Karen Adams-Gilchrist.
Thank you. Good afternoon, Madam Chair and Madam Vice Chair. Thank you for this opportunity to share my testimony. I'm Karen Adams-Gilchrist. I'm the President and CEO of Providence Center, a provider of 60 years that supports people with intellectual and developmental disabilities to discover and live their best lives in Anne Arundel County. I am honored to testify today in support of the current Developmental Disabilities Administration budget. I do want to share some perspective on the impact the pandemic has had on meaningful day providers like Providence Center. A year ago, Providence Center was supporting about 400 people with 160 staff, providing more than 500,000 hours of support. Since the pandemic, our primary source of revenue, state funding, decreased by almost 50%, and our staff count dropped by 50% as a result of layoffs and furloughs. We had no idea how significantly the pandemic would impact us when we temporarily closed most of our supports last spring. We have slowly resumed services. Today, we're providing modified supports to about 260 people. So that means close to 40% of the people we were supporting prior to the pandemic have not resumed services for a variety of reasons. In the midst of determining how to sustain these reductions, we were instituting new policies, new safety precautions, new protocols, new training requirements, and searching, and then searching some more for PPE. Needless to say, we had to think hard, not only about the current situation, but also about what our future was going to look like. Imagine that an organization that had served its community for 60 years and had become a pillar in its community was on the brink of realizing unprecedented financial losses. But what motivated us is what has motivated us for the past 60 years, and that's people. The people and the personal impact this pandemic has had on people who are more isolated, who are losing skills, losing community connections, relationships, friends, and jobs that they've worked extremely hard to gain. Yes, we have taken advantage of opportunities through the federal relief programs, of which we are eternally grateful. Are we out of the woods? Not by a long shot. But we must be ready to deliver on our mission for each and every person who rely on us. However, this won't be possible without adequate funding to help us regain a staffing infrastructure, to help us pay our staff wages that they deserve and that keeps pace with minimum wage increases, and to help us truly support people in a more innovative and flexible service delivery system. Again, thank you for listening today and for your ongoing support. On behalf of Providence Center and the Maryland Association of Community Services, I urge you to keep the governor's 4% in the budget. Thank you.
Thank you. Andy Cole?
Hi, good afternoon, Madam Chair, Madam Vice Chair, and members of the committee, and thank you for allowing me to speak today. I'm Andy Culp, and I represent the ARC Maryland, and we support the proposed FY22 budget for the Developmental Disabilities Administration. There are others who are speaking to specific components of the budget today, and I want to focus my remarks on the needs of transitioning youth. So for the purpose of this testimony, transitioning youth typically represent about 600 students per year exiting high school around the age of 21. And over the past few years, transitioning youths have faced multiple barriers to accessing adult DDA services in a timely manner if they're able to access them at all. And in recognition of this, these budget committees included budget language last year requiring a report from DDA on the numbers of transitioning youth who had not connected to services, barriers to their access, and including a plan and timeline to correct this problem. As of today, and as reported by DDA, that report has not been published. And we know that the access barriers for transitioning youth have only grown during the pandemic. As of January 31st of 2021, there are 528 transitioning youth who exited high school more than 9 months ago, who have been authorized as eligible to start DDA services, but of that number, 356 have actually started services. That's about 67%. As we're still in a pandemic, much of the delay may be a choice, but there's a good number of people who need the service and can't connect with a provider or face other barriers. There's also a number of people who graduated in June of 2019, so almost 18 months ago, who want DDA services, but after a year and a half still haven't been able to access those services. And without a seamless transition from high school into adult services, these young adults will sit home and lose skills gained over the course of their education. Two-income families may have to consider reducing to one income if one of the parents has to leave their job in order to stay home with their family member with a disability. And for single-income families, the hardship is even likely greater. So we urge that the budget committees require a detailed report again from the department and hopefully immediately to answer the questions posed last year and provide solutions to address the barriers that continue. Thank you for hearing my testimony today.
Thank you very much. And I think when I mentioned the first panel, I called Ms. Warner. I'm going to hold. I actually had another page that I missed. So I'm going to come back to you, Ms. Warner, in just a moment. I'm going to call on next Amanda Del Rego. I see you on the screen. So if you can unmute yourself, you can proceed. Perfect.
Yep. Good afternoon, everyone. My name is Amanda Del Riego, and I am on the a member of People on the Go of Maryland. I am also on the board of directors for People on the Go of Maryland. I wanted to talk about how COVID has affected me personally as an individual with a disability. I have self-directed services through the DDA. And in order for me to perform, I have self-directed services through the DDA. And I have support staff who assist me with my independent living skills. However, when COVID hit, I wasn't able to get the skills that I needed to have my support staff assist me as far as going into the grocery store and getting the items that I would need. My support staff is unable to assist me due to COVID, live my independent life. And I'm asking the committee to keep the 4% increase in the budget so that I can have my support staff to be able to assist me with my independent skills. Thank you very much.
Thank you very much. So colleagues, we've heard from Tracy Paliath, Karen Adams-Gilchrist, Andy Kopp, and Amanda Del Riego. Any questions for that from that panel, for that panel? Okay, seeing none, thank you very much all for your time and your testimony. The next panel will be Kenneth Capone,
Yes.
Laura Howell, Casey Shea, and B. Rogers. Good afternoon.
Hello, committee members. My name is Ken Capone. I am the Public Policy Director for People on the Go of Maryland. We are the statewide advocacy organization ran for and by those with intellectual and/or developmental disabilities. We are here today to testify in support of the fiscal year 2022 Developmental Disabilities Administration budget. I want to talk about the impact that coronavirus has had on people with disabilities. We have lost valuable direct support professionals because of the pandemic. We continue to have a hard time recruiting reliable staff, and now it's even harder with the pandemic. We are concerned about the impact in the future on people with disabilities and providers of community services. The 4% that Governor Hogan put in the budget for community services is crucial for the health and wellness of people with intellectual and/or developmental disabilities. I want to thank the governor for including the 4% in his budget and thank this committee for your years of support for this funding. I want to applaud the state for making sure people with intellectual and/or developmental disabilities living in group homes were counted as congregate settings and have been able to be vaccinated. The problem has been everyone else with intellectual and/or developmental disabilities has not. People in day-only programs, people who self-direct, and people who don't get any DD supports. The counties have each treated people with intellectual and/or developmental disabilities differently, and we have had to fight county by county to get them to honor the prioritization of people with IDD. People with IDD are proven to be the higher risk, and yet they are still struggling to get vaccinated. Many people with disabilities were and still are directly impacted by not having access to personal protective equipment. When vaccines came available, and we again had to advocate to be moved into a category that support the definition of the most vulnerable as most people with intellectual and developmental disabilities have underlying medical conditions. Most people with disabilities have been put in the back of the line even though we need to be recognized and treated equally. DD needs a comprehensive plan to ensure that all Marylanders with developmental disabilities can be vaccinated in the current priority category. Thank you.
Thank you very much. Laura Howell.
Good afternoon, Madam Chair, Madam Vice Chair, and members of the committee. I'm Laura Howell, Executive Director of the Maryland Association of Community Services. We represent over 100 community developmental disability providers across Maryland. I want to thank this committee, both committees, for your incredible support over the years. It is only because of your commitment that we are still standing. It goes without saying that we urge you to keep the 4% rate increase and the other expansion items in the budget. Even with the 4% rate increase, we lose ground every year in the minimum wage with the minimum wage increases. And without the full 4%, the situation would be even more dire. Also, despite considerable advocacy, and as you have heard already, DD providers will not see the expedited rate increase that the governor provided and intended to begin January of this year. We won't see that until July 1. And while it is true that under normal circumstances, this would make sense given our prospective payment system, these are far from normal circumstances. Many providers had hoped to give additional raises or bonuses to staff who have worked so hard during the pandemic. But without payment of the expedited rate increases, many of our members have indicated that they cannot provide those raises. As Ms. Wagner noted, last year, the General Assembly passed legislation to put in place measures to ensure the success of many systems change efforts underway in DDA. We believe that implementation remains critically important. Despite the pandemic and the challenges we have faced over the last year, we continue to also face an incredible magnitude of systems change efforts. And you heard some of these, but just to put this in context, in addition to changes that solely relate to the pandemic, the following is an incomplete list of the changes and challenges we currently face. Rate setting, which has been ongoing since 2014, the introduction recently of a discussion of value-based payments, the transition in the systems for billing, payments, and plans, the backlog of plans, and the challenges that some of the regional offices face in being able to process them in a timely manner, discussions of something called tiered standards, which involves a move away from more traditional services, changes in a large number of service definitions, a move to 15-minute billing increments, the move of all personal supports to the LTSS system, and hundreds of pages of new policies and procedures. I ask you to imagine what it is like to manage this magnitude of systems change without a state of emergency. And then imagine while also working to keep everyone healthy and safe, and also getting people with developmental disabilities and essential staff vaccinated, trying to manage all of that. And lastly, Vice Chair Valentino Smith, if I could just speak briefly to your question that you raised. Unfortunately, the CCSs were unaware that this issue was going to be raised in the analysis until it was too late to sign up. But they had not seen the data that DDA used or that was reflected in the analysis. And it's important to note that the data regarding when plans are submitted, that data is routinely overwritten in LTSS. For example, if someone in a regional office simply asks a question about a plan or seeks clarification, that resets the clock for when the plan is noted in the system as having been submitted. This means that CCSs cannot track through LTSS when a plan is first submitted because of the date being reset. And I understand that DDA has access to that information, but the CCSs cannot access that information through LTSS. It's also important to note that the CCSs have been using LTSS since 2018, and there continues to be significant issues with functionality and the person-centered planning process in general. And these issues create considerable obstacles for the development and submission of a person-centered plan. In the last QA report submitted by Service Coordination, Inc., the largest CCS provider in the state of Maryland, they noted 16 issues that will continue posing barriers to timely submission of a person-centered plan if not fully addressed. I know that DDA is working with the CCS agencies, but I think there is more complexity to this issue, and out of fairness to the CCS agencies, I just wanted to share that information with you based on what they provided to me. In closing, thank you for your ongoing support, and I'm happy to answer any questions you might have.
Thank you. Casey Shea.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Casey Shea. I'm an attorney at Disability Rates Maryland, where I work on the Developmental Disabilities team here. So DRM supports the DDA budget, of course, which includes the critical 4% rate increase to DDA providers. The budget also includes critical funding for transitioning youth. Also really crucial there is the foster care, those who are transitioning out of foster care, and also those who need emergency services. It's really critical for people with DD to get these services and supports that they need in order to live in the community and to pursue their life goals. But wanted to also note that the budget falls short in fully funding the approximately 4,600 person waiting list of those with intellectual and developmental disabilities who don't have access to adequate services right now, or any services in some cases. In terms of issues within the service system, I wanted to raise a few things that DRM is concerned about, or continues to be concerned about, that need attention and leadership. So first, you heard about the recent DDA amendment number 3 changes that were submitted to the federal government. That excludes children in the future from accessing the community pathways waiver, including being able to access critical residential services when it's required. So despite advocacy opposing an age cap by many advocates, DDA instituted this 18-year-old age cap for the waiver. This will harm children who need residential services, many of whom DRM has represented, who are stuck in hospitals and need DDA services in order to remedy their crises. This often leaves kids and families with no other choice but to enter the foster care system in order just to get services. So I wanted to point that out. And second, the waiver excludes skilled nursing services from the waiver, and it offers basically no alternative except for people going into nursing facilities unless they qualify for the REM program. So that's an ongoing concerning issue. And third, we also have serious concerns still about the access to personal support services within the waiver. They've changed the definition, you heard about that earlier, of many services, including this service, which has resulted in people with DD who need overnight supports being denied or eliminated those supports. It has also pushed them into another service delivery system entirely, the Community First Choice program, which has a separate case management system and is not tailored to meet the needs of people with IDD for things like behavior supports. And so this has been really harmful to many people with DD. It jeopardizes their health and safety and puts them at serious risk of institutionalization. It's also been harmful for people in self-directed services, especially who can't access a new service that DDA started called supported living. So thank you for your time. We urge you to support the DDA budget.
Thank you. And our last presenter on this panel, B. Rogers.
Good afternoon, Madam Chair and Vice Chair, as well as members of the committee. My name is B. Rogers, and I'm here today speaking on behalf of the Prince George's Provider Council in support of the DDA budget, along with some considerations for each of you. We certainly are pleased to support the 4% increase, the full funding for the governor's transitioning youth, and funding to support people who are in crisis to assist them moving into the community. All of these will be of great assistance to families and individuals throughout the entire state. As you know, the DDA providers are Medicaid providers and are reliant on the state and federal funding for their major part of their funding. This means that they cannot pass on any increases to the people who receive their services. This leads me to a couple of issues that I wanted to share with you. There are some bills that are being considered now that, if passed this session, would definitely have a serious impact on the provider's ability to operate without additional state funds. The first one I want to speak to is the Maryland Essential Workers Protection Act, which if passed as written, will impact both on the DDA providers and people who self-direct, because they will need additional funding for the implementation of the required hazard pay, additional paid leave, and worker unreimbursed medical expenses, as well as other costs that in terms of their operating expenses. Our programs are not in a position for many of their services to operate without staff, as we support some very vulnerable people who need staff support. The additional hourly cost required in the bill would be a terrible burden for them. In addition, the current bill would allow an essential worker to leave a workplace, say a group home, if he or she found it an unsafe environment, without any forward notice to the employer, putting the residents at serious risk because they could not stay there alone. Another issue is the many COVID-related worker compensation bills that presume occupational exposure. This means that workers, if they are diagnosed that having been exposed, it is presumed that they were exposed through the group home setting within 14 days of their diagnosis with COVID-19. And that results in higher workers' compensation and other expenses, even if the exposure came from outside of the workplace. There's no increase in funding anywhere to cover these increased expenses. The third issue is some of the time to care and other paid leave bills. There's no current funding to cover increases to our community for operating expenses to implement these initiatives. While very good initiatives, if the bills become law, so they become unfunded mandates. In summary, thank you so very much for the opportunity to testify today and for the committee's long-term support for the work we do. I urge a favorable report of the DDA budget and ask for your serious consideration of the additional matters I've presented. Thank you.
Thank you, and thank you to this panel. Members, are there any questions for this panel?
I hope not.
Well, you're in luck. All right, seeing none, we'll move on to our final panel. We have Marguerite Warner, Cindy Smalls, and Brianna Sweeter, and they've signed up in opposition to the budget. So we'll start with Marguerite Warner. Thank you for your patience. I think you unmute.
Okay, I
There
got
you
it.
Yeah.
Sorry, good afternoon. I am a direct care assistant at the Holly Center here on the Eastern Shore, and I wanted to testify today about the high number of staff vacancies that we have and the impact that it has on us at the Holly Center. We have, for the entirety of the pandemic and starting a little bit before that, relied very heavily on agency staff to make up our staffing needs. They fulfill an important role, but they make their own hours, they make their own schedules, and they leave us short on the weekends because they don't want to work on the weekends. This causes a lot of mandatory overtime, and it's not just the fact that we can't recruit people to come and work at the Holly Center, but we keep losing people from the Holly Center. We lose permanent state employees who then go and join and become an employee of the agency. They can still work at the Holly Center, but all of a sudden they don't have to do any mandatory overtime. They don't have to work on weekends. And the payback, or the trade-off with no longer receiving state benefits, seems to work for them. I think that this has a serious impact on the quality of care that we can give to our residents at the Holly Center. They're not getting continuity of care. A lot of times I work the second shift from 2:30 to 11 p.m. And particularly in my cottage, we have people who work from 4 to 6:30, and then somebody else comes in at 7 o'clock to take their place and works from 7 to 11. So it's that the residents aren't getting continuity of care even within one 8-hour shift. Our DCA staff and our nurses are subjected to sometimes as much as 3 mandatory shifts during a week. And this has a really significant toll on being able to retain qualified employees, especially for those people who have children at home. Can't really blame them if they can go and get the same amount of money either through the agency or at another facility, at the hospital or a nursing home, and not have to work those kinds of grueling hours. But for me personally, it's the impact that I see on our residents. We don't have enough staff to do the kinds of active treatment that we'd like to be doing with them. The active treatment component, even just as playing games or taking them for walks outside in the fresh air. These kinds of things are extremely important for them because for a year now, they've been confined to their cottages. Basically, they don't even get to move to go and visit in their friends who might live in a different cottage. So I think that's about all I had to say. Thank you for listening.
Thank you very much. Cindy Smalls?
Yes, thank you, Madam Chair, Madam Vice Chair, and members of the committee. Cindy Smalls with ASME Council 3, representing our state employees. So as all of you know, our state employees, especially during this pandemic, have seen some trying times, but continue to work through those trying times to keep our citizens of Maryland safe. I want to thank you for the opportunity. I want to thank Ms. Wagner for her great analysis and the things that she laid out in her report. I also wanted to thank Delegate Henson for lifting up one of the concerns in vacancy rates at the department. We know that because of the pandemic, the vacancy rates have heightened, but I would just like to say that before the pandemic, this has been an issue that we've brought to the agency, that we've heard from our members, that continue to be an issue with the vacancy rates. So I just wanted to uplift that that is a concern, that continues to be a concern with our state employees, doing less with more, and then with the heightening of the pandemic. Again, that's heightening even more. Lastly, I just want to say it was mentioned about facilities doing testing and offering PPEs and vaccinations. We would hope that would continue to go forth, that those state employees, those employees who want to get the vaccine would do so and have the ability to do so in those facilities. With that, Madam Chair, I thank you for the opportunity. Thank you.
Thank you. And our final presenter on this panel, Brianna Sweeter.
Hi, my name is Brianna Suter, and I am a resident associate at the Secure Evaluation and Therapeutic Treatment Program in Hagerstown. My job is to work with developmentally disabled adults, assisting them with the activities of daily living and helping engage their minds productively. But that's not what I'm actually doing every day. I keep having to act more like a security guard because we don't have enough security on staff. A short while ago, I had to break up a fight between two residents multiple times. It was a serious situation. I broke my knee and lost 2 months of work. I'm not being paid like a security guard, and I did not sign up to be one. Our center is not safe for staff or residents. The people we are supposed to be taking care of deserve better. The residents are supposed to be there for therapy. I want our residents to feel secure, and then maybe they can actually start to heal. I take my job seriously and personally. My uncle is developmentally disabled, and I've seen the kinds of places that he's been in and out of his whole life. I think that there is a better way, and that's what drew me to this job. I was excited to think that the state of Maryland wanted to provide real healing and therapy for people. The basic philosophy of my work is active treatment, taking every moment as a teaching moment. I was hired to teach the residents how to cope, how to focus on productive activities, and how to succeed towards independence. Instead, I'm breaking up fights, and no one is winning. Not me, not the residents, not the state of Maryland, and not the taxpayers. I am asking that the forensic pay bill be fully enacted and funded. We need more staff. Thank you.
Thank you very much. Are there any questions for this panel? Seeing none, I thank you all so very much for taking your afternoon to share your testimony with us. Colleagues, that will conclude the hearing on the Maryland Department of Health, Developmental, Disabilities Administration. Thank you, Assistant Secretary Yee. Thank you, members, for your questions, and certainly thank you to the public for your testimony. Colleagues, we're going to now move to the Department of Aging budget, and we will have analyst Grace Patterson, who will walk us through her analysis. Good afternoon, Ms. Patterson.
Good afternoon, Madam Chair. Thank you so much. It's my pleasure to present the Department of Aging's fiscal 2022 budget analysis. Going to the budget summary, the budget decreases $13 million from fiscal 2021, and this is mostly driven by the federal coronavirus recovery funds included in fiscal 2021. The analysis doesn't really get into the funds provided in December through CARISA. Most of these funds were brought into the budget through supplemental budget number 2, but that's not reflected in the analysis. Going to the discussion, I'm going to start with fiscal 2021. $15 million was brought in to the budget of federal funds from the FFCRA and CARES Act. And then supplemental budget number 2 also adds $790,000 of federal funds through CARISA, but again, this is not reflected in the budget data in this analysis. There are 2 proposed deficiency actions for the fiscal 2021 budget. The first one pertains to the Senior Center Operating Fund. In fiscal 2020, about half of the appropriation to the fund was reverted in error, so a deficiency is provided to make this non-lapsing fund whole. And then a negative deficiency withdraws $250,000 from the Durable Medical Equipment Reuse Program. This funding was unneeded in fiscal 2021. In fiscal 2020, expenditures for the program also did not exceed $1 million, so the Department of Legislative Services recommends to level fund the program in fiscal 2022 as well. Cost containment actions removed $2.1 million from the agency's budget. $2 million was for discretionary program enhancement funding, and the General Assembly fenced off $470,000 of that discretionary funding for the state nutrition program, but all of this funding was removed in cost containment. Going on to the targeted reversions, there's one for the Community for Life program, removing half of the program's appropriation in fiscal 2021. DLS also recommends to level fund this program as well in fiscal 2022, and I'll discuss that more later on in the presentation. Now moving to the fiscal 2022 budget discussion. About half of the allowance is to administer various federal programs. Administrative expenditures, including personnel, makes up less than 10% of the allowance, and the remainder are state programs as shown here in blue. Going to propose budget changes. As I mentioned earlier, the federal funds included in fiscal 2021 from the various federal coronavirus recovery packages drive the decrease from fiscal 2021 to 2022, but this is partially offset by the restoration of some funding that was removed in cost containment actions for fiscal 2021, including reducing the temporarily increased turnover rate for fiscal 2021. It's now reduced by 2.5 percentage points. In addition, funding for the Community for Life program and the Durable Medical Equipment program is restored to what it was originally funded at in the fiscal 2021 allowance. The Maryland Senior Call Check program appropriation increases by almost $200,000. And those are the major changes there, but each program's funding fluctuation is summarized in Exhibit 3. Now going on to personnel, 2.6 contractuals are removed in the allowance, but most notable about the personnel data is that more than 1 in 4 positions are vacant in the agency. In addition, over half of the agency's positions were vacant for 12 months or more in the past 5 years. MDOA has had a consistently high vacancy rate. Then DLS has one key observation to present about the cost effectiveness of the department's 2 new programs, the Community for Life program and the Durable Medical Equipment program. Community for Life is intended to support aging in place by providing service navigation, home maintenance services, and transportation services. State funds for the program provide seed grants to nonprofits or local governments who then agree to administer the program for 5 or 6 years. However, during the pandemic, services can't be provided as originally envisioned. Only service navigation remains uninterrupted, but DLS notes that both area agencies on aging and senior centers provide service navigation and programming. In fiscal 2020, fewer than 200 members participated in Community for Life throughout the entire year. These members pay membership dues, but membership dues comprise a small share of overall grantee revenues. In addition, CFL grantees' revenues on average were insufficient to cover average expenditures. In fact, one grantee's expenditures exceeded revenues by during the pandemic, it's difficult to the effectiveness of this program, but new grantees in fiscal 2021 and new grantees in fiscal 2022 will have a difficult time, likely have a difficult time administering the program during the pandemic. So DLS recommends level funding the program at the reduced fiscal 2021 level of $300,000. Going on to the Durable Medical Equipment Reuse Program, this program is expected to accept equipment donations, sanitize and repair the equipment, and then distribute it to the public free of charge. So far, about $900,000 in equipment has been collected throughout the program's existence. However, the program has been appropriated almost $2 million. So the return on investment there is unclear. It's also unclear whether there will be sufficient equipment to meet the demands from the public, or whether this is the most effective way to administer or provide durable medical equipment to the state's residents. So given the concerns about these 2 programs, DLS recommends adopting language requesting data on the 2 programs, but also on the department's waitlist, as both CFL and the DME program have received over $3 million throughout their implementation. There are substantial waitlists in some of MDOA's programs, including the senior care program that has over 2,000 people on its waitlist. So here is that language recommendation. Then there are the recommendations to level fund the 2 programs. And then there's also a recommendation to get more information about how the department is working with other state entities to encourage DME donations and the overall administration of the DME program. And that concludes my presentation. I'd be happy to take any questions.
Thank you very much. Are there any questions for Ms. Pedersen? I see, Mr. Chair, I don't see any questions. All right, thank you very much. Well, with that, colleagues, we'll turn to the Department of Aging. I know that Secretary Kramer's been here for a while, patiently waiting. Good afternoon, Madam Secretary. Would you like to introduce your colleagues, or would you like me to? Oh, we've got to unmute you.
There you go. I had unmuted, but evidently I was remuted.
Okay.
Good afternoon, Chairs Griffith and Resnick and members of the subcommittee. It is great to be here with you. I would like to introduce The two people that I expect might be speaking if we have questions, and that is our Chief of Staff, Pam Seidel, and I believe that our Fiscal Director, Linda Weaver, is on the call as well. Forgive me, I can't see everyone who's in the room. This is a bit difficult, but you've been dealing with that all session. No apologies, first of all, Madam Chair, for the delay. I listened to the entire hearing that you held before ours, having served on the Senate's Health and Human Services Subcommittee for many years. I found it to be very interesting, and some of the same people are still testifying. They're very dedicated people.
Yeah.
I appreciated the opportunity. I'd like to thank our DLS analyst, Grace Pedersen, for her analysis. I had hoped to give you an overview of 5 new innovative programs that we brought into the department to your constituents during the pandemic that were strictly pandemic related. I won't do that given the hour, and because I know that we have some witnesses to testify. So I won't do that, but I would look forward to providing that information to any of you who would like to hear about it. We've had some spectacular new programs. I would like to note that we have served, it's about 6.5 million home delivered meals during the pandemic. And that is at some points during this pandemic, a 500% increase over our pre-pandemic numbers. Of that, a good deal of those, about 350,000 of those meals were provided by your neighborhood restaurants. We started a program to support your local restaurants so that some of this CARES Act money that was coming into the state would be used to support them, as well as to create some really fun meals for our seniors to whom we're delivering. So all of your clients, your constituents have had that opportunity. None of this would have been possible without our spectacular area agency on aging work. They are the ones that got those into the hands of your constituents, their clients, and they have all been absolutely fantastic during this pandemic, as they always are, but they stepped up. I'd like to go to the first issue, and that was the analysis of vacancy. And what's missing from that analysis is the fact that the Department of Aging has for many years had many long-term contract positions. The analysis describes the regular positions. We've had many of our staff who came in wanting contract positions because they did not intend to stay in state service long enough to vest in the state's system. So they have been, we've had our fiscal director over a period of time, our director of innovations, our CCRC director for a long time were contract positions. So these were permanent positions, but they operated as contracts. We have now filled, because as you've heard, we've expanded our programming. We've filled or will have filled within the next 45 or 60 days, all but 3 of our regular positions. But in addition, we still have many contract positions and that we have filled. And so in fact, the analysis gives the impression that there are empty desks, 28%, almost a third, sitting empty in our department. That is not at all the case. Those, with our long-term contract, not our part-time contract, but just our full-time contract and regular positions, we are 100% filled +4 by the end of our recruitment that we've got going on a few positions. So please do the analysis considering those contracts. And I can tell you that the contract is favorable frequently to older staff people who come in who've already had a career. And we certainly want to be able at the Department of Aging to accommodate employing our older adults. There was a question about institutional knowledge. We are 20 of our staff people, that's almost half, have been in the department for at least 4 years. 8 of them have been at the department between 8 and 26 years. Our assistant AG, our lead assistant AG, has been there for 26 years. He's been with us. And so, of course, we like to have long-term employees, but we're not concerned that there isn't a great deal of depth and understanding of our programs. We believe that there are. Before getting into a discussion of the our innovation programs, the 2 that we'll be discussing today, I need to tell you and remind you of the overarching theme across the nation in aging programs, and that is the huge population boom. We cannot look at what we're doing without considering, in any of our programming, without considering the fact that our population, the people that we serve, the older adults, the population is increasing in Maryland alone by 36,000 people on average each year, and will continue increasing until 2045. So if we, let me also say that we don't expect any huge new increases in our funding. The majority of our funding comes from the federal government. We have not seen increases other than aside from COVID funding for COVID-related purposes. But in our regular program funding, we're not seeing increases that will maintain the same program functioning for all of those additional people. So what do we have to do? We must move our services up the timeline and prevent many of those older adults from spending down and becoming eligible for our aging programs. We need to keep them staying in their homes, healthy in their homes, so that they do not have to go into higher levels of care where either Medicaid pays for them or where they have spent down and are therefore eligible for the majority of our programs, like senior care, which was mentioned. That's why we have these innovative programs. It is to start moving our services up the timeline to serve our residents that don't yet need the AAA services that we provide and keep them living healthfully at home. So what I would like to do to start the discussion of Community for Life so that it can be explained succinctly and efficiently to you is to show you a video that we have produced that our Community for Life providers are now using to explain and market the program. And I'd like to also note that while you're watching this video, any of the pieces of the video where you see me speaking as the Secretary of Aging, the video has been designed so that my pieces can be taken out, and anyone who is then either Secretary of Aging in the future or in another position that wants to fill in those pieces, that can be done very easily and at very little cost. Just
Madam Secretary, can I ask how long the video is? Just
8 minutes. 8
okay.
minutes, Madam Chair. And my explanation of it and description would have been a bit longer.
Really? Okay. I think what we'll go ahead and accommodate this, at least a part of it. But what I would say is I think members, the Friday afternoon and members still have bill hearings and other work. So I know that people are interested, and I saw Mr. Edwards here and getting a quick update on what's happening with the durable medical equipment program. Before we get to the video, Mr. Chair, members, did you have any quick questions for the Secretary? Or comments?
I do not, but actually, given the hour, Madam Chair, and with no disrespect to the Secretary, I know that my subcommittee still has some work to do this evening. Would it be possible to email all of us the video, and then we can enter that into the formal record?
Yes, I would. May I respond, Madam Chair? Yes, I would. That is possible. Please, I would ask you to take the time to watch it, because it really does explain the program, and without that, it would you would not have all the information you need to discuss the recommended cut to the budget for that program.
No, I do appreciate that, and I know you took time to meet with me in virtually in my office and walk us through that program, and committed to watch the video. But I am mindful of the bill hearings and other things that folks have this afternoon. So knowing that we will get our detailed information on the Communities for Life by viewing the video, are there questions for the Secretary and her team as it pertains to the budget analyst's recommendations or anything she shared?
Madam Chair, excuse me, but I still have some other comments to make. That was not
final. Okay. Oh,
Thank
okay.
you.
My apologies. My
Thank
apologies.
you. I appreciate it. So the Community for Life program, as we've just discussed, and you'll see, its purpose is to keep people living at home. If Community for Life keeps just 6 people a year, the entire statewide program, if it keeps just 6 people out of a nursing home on Medicaid, it's more than paid for itself. You'll hear from some of our nonprofits who are providing these services. The analyst noted that the nonprofits are putting in their own funds to, and as well as their services to make this program work, and said that that was a problematic. It is in fact our model. Our nonprofits have been serving these seniors in their communities for decades, and they intend to support this to some extent, along with membership fees. So that in fact does not show that the program is not operating properly. In fact, it is. You'll see that when you watch the program, that the membership, the membership is at the point where we are just working into selling this program and marketing it. We've had an entire year of pandemic where we had difficulty and we were not able to grow in our membership as much as we like. We are ready to take off now. And I must say that in spite of the pandemic, we went from 6 Communities for Life, all but one are county-wide, and now have 10 even during the pandemic. I'd want to note that we anticipate using all of the 2021's $600,000, and that we cannot continue to grow the program without the full $600,000 in the 2022 budget. We have maintained that in as low as possible. So I thank you for your consideration on that. The point was made that service navigation in the CFL program is duplicative of AAA and senior center activities. It is not at all. They are not the same. Our CFL service navigators are trained through a program that's been developed for that purpose. They are much more personalized and frequent in their interaction and serve an entirely different purpose than our AAA programs. To move on to the durable medical equipment reuse program, we opened our 60,000 square foot warehouse at the end of August this past year. The program has taken off magnificently, much better than we had originally anticipated. You have photos in your packet with our response so you can see what it looks like and how we've done in bringing in equipment. Just since September, when we first opened, our equipment donations have averaged a value of $173,000 per month, which would then mean at the end of the year, we should have the equipment at least valued at $2.1 million when our state investment is $1.2 million. We have everything from rollators to many motorized wheelchairs, many of which are valued at $15,000. And we are able to give those away to your constituents free of charge. We're going to have sites, we already have many of them opened all over the state so that your constituents don't have to go to Cheltenham in Prince George's County, where we have our headquarters and the warehouse. We have already saved the state's landfills the equivalent of 34,000 cubic feet of space. That's the equivalent of 3 two-story, 3-bedroom homes already. And imagine what the savings to our environment will be once we have a full year of this program. It is spectacular and something that giving a grant wouldn't provide. We just got a call last week from Howard County with a constituent that is coming out of the hospital after spending a great deal of time there with COVID. And the family was looking to bring him home and needed a great deal of equipment to do so. Howard County asked us, and we were able to provide a powered Hoyer lift, an electric hospital bed with bed rails, and an airflow pressure relief mattress, all free of charge for this family, and took it to them. And in addition to that, we've received calls from Howard County and Montgomery County asking for wheelchairs for their vaccine sites. We've provided numerous wheelchairs, 15 to each of those, and 60 to the state's mass vax center. The cost would certainly be more, the value, than a grant could supply. Otherwise, I'd be happy to do the grant because we don't need the extra work. We provide a very fast turnaround, sometimes within a day. And of course, then the environmental benefits have got to be weighed when making this decision. The analyst questioned our interaction with other departments about this program. You should know that when we started this program, this concept 5 years ago, we convened a committee of the secretaries of the Department of Health, the Department of Disabilities, Human Services, and Veterans Affairs, and all have been part of the process. No other department distributes the equipment that we do. In addition, I can tell you that Secretary Beatty has been a complete partner in developing this program. Recommendation 3 would remove $250,000 from this program because we have not spent all of that. We reverted it last year. We reverted it because we were not open for a full year, and we have not put our efforts into distribution yet because of the pandemic. The people we serve, of course, are vulnerable. And so we have not fully opened and are doing so in the coming month or two to fully distribute equipment beyond what I've already told you. I can also tell you that we at the Department of Aging have included in our the cost of the director of that program as well as the front office manager in our budget. We have not spent program funds on that. We have included that in our otherwise unchanged operating budget. In conclusion, the DLS analyst said that we had low utilization of these programs. They're both extremely new programs. And so we are now at a point where we're ready to take off. When electricity was first developed, everyone didn't have it. It had to be marketed, and it had to be explained to people, just like our programs. We're very glad that they went to the trouble and did it and didn't terminate electricity use, because it took some time to ramp up. We're there now. We have put in the groundwork. We are now ready to open, and certainly that's already happened in durable medical equipment. And in Community for Life, now that the pandemic is ending, we have every reason to believe, and so do our providers, that those numbers will be growing dramatically and that we can expand. We do not anticipate turning back the $300,000 in the Community for Life program. We actually are very close to signing a grant agreement, and hope that and have every reason to believe that that will be committed and spent this year. I want you to know that I have no problem providing the requested reports, but that taking money from either of these programs would be very detrimental. We are very, very cautious about the way we spend money at the Department of Aging, and we will not spend anything that is not absolutely necessary. But for us to be ahead of the curve in order to serve your older adults, your seniors in your community, we have got to bring these programs to full fruition. So, and I might also note that we have cut spending at the Department of Aging for administration since this administration came in by 28% over prior funding, with far more programs. Thank you. Happy to take any questions.
Thank you, Madam Secretary. We certainly hear your passion for your programs and services, and certainly join you in thanking the Area on Aging folks that are out in our communities on the ground. Members, I don't see any hands raised. Are there any questions for the Secretary? Okay, thank you very much. We look forward to getting the link for your video, and I look forward to watching that on our time. We do have several public witnesses who've signed up. It looks like we can handle them in two panels. So as I did with the previous group, I'll call one panel. We'll hear from them. I'll pause for questions, and then we'll move to the second group. So we'll start with Rose Lee, Michelle Douglas, Andy Schweitzer, and Valerie Bigelow, in that order. Rose Lee, you can begin.
Okay. Thank you, Chairs Griffith and Resnick, and Vice Chair Valentino Smith, and members of the committee, for allowing me to provide testimony in support of full funding for the fiscal year 22 operational budget for the Maryland Department of Aging. My name is Rose Lee, and I'd like to express my support for the innovative programs that the Department of Aging has created, including the Maryland Community for Life program, the Durable Medical Equipment Reuse program, and so many others. I'm currently president and CEO of Rose Lee & Associates, or RLA. We provide scientific management support to research-centric organizations, including the National Institutes of Health. Prior to founding RLA, I was a branch chief at the National Institute on Aging, responsible for research grants in the area of population and social processes. I currently chair the State Commission on Aging, which advises the department and the secretary about ongoing programs and need for new programs. Suffice it to say, I have been following the research on programs related to aging populations for over 30 years. I know I don't look it, but it's been 30 years. And what has been happening under the current secretary's leadership has been really gratifying and impressive. As Secretary Kramer indicated, the needs of a growing aging population cannot be met with existing resources. It's just not going to be possible. The CFL is the future of aging, a way to support seniors as they age, to make it possible for them to live as long as possible in their own homes and in their own communities and not nursing homes. The department is seeking to provide just seed funding to establish the CFL and expects the program to rely over time on membership fees and contributions from nonprofits. It needs time to establish its roots. The Durable Medical Equipment program, which takes equipment like wheelchairs and walkers that are destined for landfills and recycles them for use by those in need, is another first in the nation type of state program that Secretary Kramer championed and brought to fruition, which will benefit thousands of Marylanders over time and help save the planet too. Having chaired the Commission on Aging for now over 4 years, I can say with full confidence that the agency leadership is committed to being innovative and forward-thinking. I urge you to reward this already thrifty and value-adding institution and department with your support and full funding so that it can continue to do what it does best, which is working for Maryland seniors to bring evidence-based programs that work, are cost-effective, and are sustainable. For that reason, I ask that you support funding to expand and grow the department's innovative programs, not suppress them, and to support the department's carefully considered budget request for fiscal year 22. Thank you for your consideration.
Thank you. Michelle Douglas.
Thank you, Madam Chair, Mr. Chair, and members of the committee. Michelle Douglas, on behalf of the Maryland Association of Area Agencies on Aging, known as M4A, which is made up of the 19 local area agencies on aging that serve well over 1 million older adults with complex and varied needs around the state. As you can imagine, the past year has seen tremendous challenges as the AAAs have worked day and night to meet the needs of and assist Maryland's older population, those who are most at risk for illness and death due to COVID-19. Senior centers closed to the public, in-person meetings with professionals and customers ceased, transportation services were suspended, congregate meals ceased, and massive feeding of seniors across the state began. Through the CARES Funding Act, AAAs were able to adapt and to adjust to provide some of the most critical needs, like the nutrition services. They massively increased the home delivered meal program and implemented new state initiatives for the restaurant and meals and for grab and go meals across the state. We want to thank the governor for the additional $2.7 million in federal funds for home delivered meals as passed by the federal government. M4A respectfully requests the committees include narrative that would ensure the additional nutrition funds, the $2.7 million, be designated solely at the discretion of each local AAA, because each jurisdiction is unique in its needs, resources, and sustainability. AAAs then would, in order to meet their community needs in the most effective and cost-efficient way, determine whether and how much of the additional nutrition funds would be set aside for the restaurant initiative or any other new nutrition initiative. Also want to note that throughout the pandemic, AAAs have been providing vital assistance to their sister agencies, including the local health departments. Many AAAs are providing critical operations related to COVID-19, including staffing vaccine call centers, assisting with mobile vaccine clinics, identifying senior independent living facilities for vaccines, and many other needs as they arise. AAAs that are running transit systems also stepped up to deliver meals to their local boards of education. They help to ensure student nutrition during school closures and temporary suspension of public transit service. With the exception of nutrition services, all of these additional tasks have been completed without any additional state or federal pass-through funds. So we do urge the state to provide additional funding for AAAs in light of their ongoing pandemic-related work and their unbudgeted resources used to provide assistance to their sister agencies. This continues to be an incredibly difficult time for AAAs and for the older adult population. So we really appreciate the flexibility to make the best use of the funding. It is M4A's mission to ensure the safety and well-being of older adults as always, as well as throughout the entire COVID-19 pandemic, and then be able to sustain them beyond. And finally, we want to thank you for the courtesy extended today that made it possible for some of the AAA directors to join in on Zoom. We really appreciate that, and we are here to support the budget.
Thank you. Andy Schweitzer.
Hi, good afternoon. I'm Andy Schweitzer. I'm the director of the Community for Life program at Broadmead. That's in Baltimore County, Cockeysville, Maryland. I would like to thank the Chair Griffith and Chair Resnick and the other members of the committee for allowing me the opportunity today to talk in support of the Maryland Department of Aging's Community for Life program. Broadmead is thankful partner with the MDOA for the countywide program in Baltimore County. We are a Quaker-based nonprofit organization. We were born out of a Stony-run Quaker meeting in Baltimore City in the late 1970s. We have around 500 residents and 300 employees, and we have provided exceptional senior living, assisted living, and nursing care for over 40 years. While this is our reputation and legacy, we have always strived to serve a more diverse population, especially those individuals who may be less fortunate or less able to connect with services. This is part of Broadmead's mission, which is rooted in Quaker values. When the opportunity to be a part of the Community for Life program was presented to us, we jumped on it. Community for Life represents the future of aging services and is a sustainable model for CCRCs or life plan communities to take their expertise to the greater community. We believe in it so much that, in fact, Broadmead has been a financial supporter of the program since the beginning of the partnership. These contributions represent and are aligned with our charitable mission. A small fraction of older adults live at life plan communities because of preferences or financial reasons. Older adults want to age in place in their home, and that is where Community for Life steps in. Community for Life helps their members with life, helps protect their assets, which is oftentimes their home, and helps prevent the likelihood of them relying on state services. We provide services to members in a proactive, predictable, and affordable way. Plus, they can rely on us. When we say we're going to do something, we do it. If any of you have had a contractor come to your house, that's not always the case. For something as simple as changing out the filters in your AC unit to something more as extensive as putting on a new roof. Initially, Broadmead wasn't a countywide partner, but made that expansion this past year. Yes, during the pandemic. We did this now because more than ever, individuals are staying in their homes. They're aging in place. Mentally, physically, socially, they need a trusted friend to help them. At the beginning of the pandemic, we definitely weren't providing the same level of services that we were pre-pandemic. However, in late fall, we started to see quite a bit of traction. The outreach efforts were reaching more people, in part because of name recognition and the expansion across the state, plus the marketing efforts, but also through word of mouth, reputation. Word was spreading that people and members of Community for Life were receiving exceptional services, and their friends and neighbors wanted the same. Broadmead is in full support of the Community for Life program, and we stand in support of not reducing the funding this next fiscal year. This budget would help the program to expand, potentially even statewide. This would, again, not only help more people across the state, but it would help out our program in Baltimore County through that name recognition that I already talked about. Community for Life is truly a unique program that you won't find in other states, and it does have a tremendous impact on those we serve and those we'll serve in the future. Thank you for this opportunity.
Thank you. Valerie Bigelow.
Hello, I'm Valerie Bigelow. Here's my husband, George. And we have been living in our little 3-bedroom rancher for 48 years, and we want to stay here. We joined Community for Life about 1.5 years ago. We both have a little bit of arthritis, maybe me a little bit more. I don't want my husband climbing ladders to change light bulbs and falling, which he did about 20 years ago, and now he's older. So Community for Life is giving us peace of mind. The service navigator first came to our house and she looked things over and she said, oh, you need another banister going down to your basement because it's not safe. And she provided the person to come and create from scratch a whole new banister, and now we feel safer going down the stairs. We've had when a snowplow knocked over our mailbox, what do? We call Community for Life, and 2 days later they provided somebody to fix that. That's heavy work. My husband can't do that anymore, and we really appreciate it. So we've had many things done. We feel that now we can stay in our home, which works for us, and we really appreciate the service. Did you want to say?
Yes, so we both want to speak in favor of continued support and expansion to the Community for Life program. We've received a lot of benefits from it. It's provided us guidance. It's helped us provide services that increase our safety at home and reduce the risk of falls. It's helped us do maintenance around the house that improves the appearance of the house or maintains the appearance of the house. So the services overall are good for us in terms of safety, and they're good for the community in terms of maintaining our property.
I have one more thing to add. The one thing that gives us peace of mind is that the providers the Community of Life send to us, we can trust. They're not going to rip us off because we're older, and we just have full confidence in whoever they send us, and they've been wonderful. I think that's all we have to say.
Thank you.
Thank you.
Thank you very much. Are there any questions for this panel? Okay, I see none. Thank you all so much for sharing your testimony and your afternoon with us. Colleagues, we have one more panel. And so we will hear from Rob Hart, Mandy Arnold, and Maria Darby. Good afternoon. Is Rob Hart here? Oh.
Good afternoon, Madam Chairperson.
Oh, there you go. Okay.
Here we go. My name is Rob Hart, and I want to thank you and the subcommittee members for letting me speak on my support for Community for Life. I am the director, developmental director for the Worcester County Commission on Aging in Worcester County, Maryland. Worcester County has had a Community for Life program since the spring of 2018. We started out in the Ocean Pines area of Worcester County, and we are glad to now serve the whole county. We were only able to serve the whole county because of the partnerships we have built with Community for Life. Civic groups, the local towns, and the county have started funding us. We are now will be fully funded without any state money at all in this program. Our partners, our Maryland Access Point partners, our civic groups have helped subsidize some of the seniors that could not afford a Community for Life program. Some of these seniors actually have come from other programs that we service here. Our Meals on Wheels programs, our senior care programs. We have lifted these seniors out of those programs that the state paid for into now a membership program that they're helping to pay for. That's what this Community for Life program can do. We're also seeing some savings for other community organizations like the fire and EMS departments. Now that we are helping them with their most frequent flyers to get them out of the hospitals and not so many calls to our volunteer fire departments. We also are transporting seniors to our senior centers now that are Community for Life members that used to not have the ability to get out and socialize. So with that, and due with the late hour that you all have been serving, I want to thank you all for supporting the Department on Aging and supporting the Community for Life program.
Thank you. All right, Mandy Arnold.
Can you hear me?
Yep.
Great. First, I'd like to start off with thanking the chairs Griffith and Resnick and the subcommittee for the opportunity to testify on behalf of the Maryland Department of Aging operating budget. I'm the president and CEO of Partners in Care, a nonprofit organization that's been in operation for over 27 years in Maryland. We serve Anne Arundel, Talbot, Caroline, and Frederick counties to support the seniors with the services to age in place. Partners in Care has received funding from local governments in these jurisdictions to support the services we provide to seniors. Before partnering with the Maryland Department of Aging, PIC, which is Partners in Care, provided similar services to the Community for Life through a volunteer model. The Community for Life provides a tremendous enhancement to our existing programs by providing members with the services that prevents fraud, falls, and spending. The Community for Life will prevent the need for more expensive programs in the future by preventing the typical problems associated with aging. Seniors want to age in place. Programs such as the Community for Life, Partners in Care, we prevent social isolation, loneliness. We assist with medication adherence. All of the items that cost the systems millions of dollars if not prevented. For this reason, I ask that you please fully fund the Community for Life program. And I thank you for your time and your continued support.
Thank you. And Maria Darby.
Hi, I want to thank the chairs as well as the members of the subcommittee for the opportunity to testify today in support of the Maryland Department of Aging's budget, specifically the Community for Life program. I am Maria Darby, the Chief Operating Officer for Keswick, an organization that has served older people for over 137 years through campus-based services, and for the last 5 years has expanded services to include community dwelling older adults. As the COO, one of my areas of focus is Keswick's Community for Life program, serving all of Baltimore City and parts of Baltimore County. Recognizing that 25% of Marylanders will be over the age of 60 by the year 2025, and that 13% of Baltimoreans are already over the age of 65, Keswick leapt at the chance to become one of the earliest Maryland Community for Life programs aimed at keeping older people healthy, mobile, and at home. We believe that one of the most important elements of an older person's health is the ability to age with dignity and remain healthy and independent for as long as possible, something on which most people agree. As a matter of fact, according to a 2018 AARP report, 3 out of 4 older adults surveyed responded that they would like to continue living in their own homes and communities as they age. Communities for Life recognizes the importance of older adults being the drivers of their own lives. CFL supports their efforts to remain safe and independent, to manage chronic conditions, to utilize local resources, and to maintain social and community networks by offering access to individualized, quality, vetted services that enable them to live well, age well, and be well in their communities, paying taxes and contributing to the economic base of the state. By ensuring that the home environment is safe and user-friendly, we address one of the root causes of hospitalization for older people, falls, by preventing the very first fall, often that happens during regular home maintenance, and then often leads to a downward health spiral for many older people. Moreover, the CFL program helps defer the need for participants to move to an assisted living and/or nursing home where they will likely outlive their assets, causing increased strain on an already stretched Medicaid system. The seed funding that MDOA provides to new Community for Life initiatives is critical. It helps leverage additional private and philanthropic funding more than 10 times over, as well as acting as a seal of approval to the public, creating trust and goodwill among the ever-growing aging middle-class population. The Keswick community strongly urges the committee to support funding for Maryland Communities for Life at its original budgeted request of $600,000. This small investment from the state will have a significant positive ripple effect on the lives of Maryland's older adults. Thank you.
Thank you very much. Are there any questions for this panel? Well, we thank you all so much. As a matter of fact, thank you to all the public witnesses. We know that your hearing was going to be earlier and you all gave us a lot of time this afternoon. So we really appreciate your staying to share your remarks with the subcommittees. Colleagues, are there any questions? Outstanding. Well, I believe, Mr. Chairman, this is the last budget hearing for the joint committees on budget and tax and appropriations for this session as we move into the next phase of our work, which will be reviewing the analyst recommendations and the agency responses and preparing to make decisions that we will offer to our full budget committees. But I certainly want to thank my colleagues on the Budget and Tax Subcommittee on Health and Human Services. They are Senators Addie Eckert, Senator Jim Rosapep, who's the Vice Chair of Budget and Tax, and Senator Ron Young, who's his first time on our subcommittee this session. Certainly welcome you and thank you. And also our colleagues on the House Appropriations Subcommittee, Chair Resnick, Vice Chair Valentino Smith, Delegates Henson, Mangione, and Delegate Young. It's been our pleasure to work with all of you this session. We have fantastic budget staff, committee staff on both appropriations and budget and tax, and have had some incredible analysts this session that have done a deep dive in each of the areas that we have jurisdiction over. And so I just want to thank everyone. And we've heard from the public on, I believe, every area that we have jurisdiction over. And so it's been our pleasure to hear from each of you and to get input from each of you. Any closing remarks, Chair Resnick? You're muted.
That was a moment. I kept hitting the volume button on my computer.
I could tell you were saying something riveting.
So no, thank you. Thank you, Madam Chair, and I appreciate everybody. I want to apologize to everybody for being very late today. A couple of other meetings where I was not able to break away from, but thank you to everybody. And it was a very successful hearing schedule. And obviously the people that we had heard in the days and weeks prior to this one are not here to hear that, but we're very happy about the way this turned out. I really love this joint House Senate format, frankly, and maybe we can figure out a way to continue it back in real life next session.
Above my pay grade.
But thank you all again, and look forward to decisions, which will be next week, I think.
Thank you. And Madam Secretary, don't forget the video link. Thank you all so much. Have a great weekend. For those